Hello.
Good afternoon, San Donato.
Hello. Good afternoon.
It's Alison Sabalka, joined by Maria
Apologize, we are
Gagliardi,
late.
Kevin Walsh, and Oliver Stumper.
Okay. So apologize, we are late because this is an interesting case that needed quite a lot of time to be ready. So we are here working with Dan Agler, Luca Junior, all the staff of the Cath Lab. I will ask firstly Angelo Micheletti to introduce the patient.
Good afternoon to everybody. This is a 43-year-old man, body weight 88 kilos, who had an initial diagnosis of a bicuspid and stenotic aortic valve and isthmic coarctation. When he was 2, he underwent a percutaneous aortic valve balloon dilation. Then when he was 5, he had a surgical coarctation repair. Subsequently, due to progressive aortic valve regurgitation, he underwent, when he was 24, a Ross procedure using a 29 millimeter homograft in pulmonary position. Then, unfortunately, due to neo-aortic valve regurgitation and aortic root aneurysm, he required a new operation. A dental procedure was performed when he was 39 years of age, using a 23 millimeter aortic valve mechanical prosthesis. And at the same time, the pulmonary conduit was replaced with the Vascutec Elan 23 millimeter. Clinically, he's complaining some degree of exercise intolerance. On physical examination, there is an ejection systolic murmur at the upper left sternal edge. The ECG shows a sinus rhythm and superior axis deviation. Chest X-ray shows some degree of right ventricular dilation, as you can appreciate in the lateral view. On echo, there is a moderate tricuspid valve regurgitation and an increase estimated RV systolic pressure, about 75 millimeter. Due to a moderate to severe conduit stenosis, the peak gradient about 65 millimeter of mercury, with only a mild regurgitation. The aortic valve prosthesis is well functioning. On MRI, the volume of the right ventricle are within the normal limits, good systolic function, mild pulmonary valve regurgitation, and moderate to severe pulmonary valve stenosis was confirmed. A CT scan was performed as well, showing normal coronary arteries, moderate conduit calcification, and dilated both pulmonary artery branches. And based on the CT data, in collaboration with the engineer from Politecnico in Milan, some computational 3D models were created in order to better understand some issues. First of all, the relationship between the coronary arteries and the conduit. And coronary arteries seems far enough for a safe balloon dilatation. Second, the disposition of the calcification, as you can appreciate in red color in the picture on the left side. And then the relationship between the aortic tube course and the pulmonary conduit.
Okay.
Resulting in a sort of oval shape, as you can appreciate in these pictures. So the intended procedure is go forward for a percutaneous pulmonary valve implantation.
Okay, thank you, Angelo. Can we be okay? So maybe then we can show the angios.
So the first angio here is an injection, as you can see, through the catheter in the right ventricle, and shows this kind of diffuse stenosis beginning in the distal part of the conduit and then extending out to the pulmonary artery bifurcation. And so then the next picture was, we have an aortogram that shows, the next one shows the the coronary arteries a little. Okay, so we put a balloon in and then inflated that, and then we can see that the right coronary is not filling very well. And actually, that was an impression on that. On the previous injection, the right coronary filled well. With this balloon inflation in the conduit, the right coronary now doesn't fill very well.
Which size
then
balloon
we-
is that?
This is a 23 millimeter balloon inflated by hand, but it pretty well filled most of the conduit, as you can see, and obviously did something to the right coronary artery because it was not filling well. So we thought we should selectively inject that. The next pictures then show.
Next.
This is an injection without the balloon in the right coronary artery here, and you see it's right in the orifice, so we're not selectively down into the coronary, but it's in the orifice of the right coronary. And then the next one shows an inflation of the balloon again, and the right coronary again is not filling very well. You can see that we're a little bit more proximal. We're inflating the proximal part of this conduit in these inflations. And so we weren't sure why this was happening. That it doesn't look like the balloon is pushing on the coronary, but it could be some material outside of the conduit that's pushing on the right coronary to make it fill in this manner. So we were very concerned about that. So then we went to the next one. We used an Atlas balloon, I believe.
Next. Next. Next.
Yeah, there you can see with that injection it fills well. Here's another inflation showing it something's wrong with the right coronary artery again. So the next one,
But it's much further down.
we put an Atlas balloon in, and here again you can see the same problem with the right coronary artery, that something's, even though it's not right on the right coronary, there must be some tissue that's pushing it and compressing it.
The orifice looks. Also the orifice of the right
The orifice
coronary,
of the right
yes.
coronary looks a little strange. So, so we were very concerned that we would not be able. You see how proximal the balloon is in this situation, though. So we put the balloon out farther. The next one,
We do.
and we did a
actually-
rotational angiogram with an injection in the aortic root, and with the balloon out farther, surprisingly, the right coronary fills pretty well. Don't see very much problem with the right coronary artery. And that, with the balloon in that position, and we had the three-dimensional reconstruction, you can see that that shows the right coronary pretty well. And the left coronary also is normal.
Which size Atlas is that balloon?
That's
Is an Atlas.
that's the Atlas, 2 centimeter length Atlas balloon. So we thought, wow, that's strange. But we were happy that distally, we seemed to be able to inflate the balloon there without causing obstruction of the coronary. And in fact, when you look at the original angiogram, a lot of the stenosis is out at the at the connection of the conduit to the pulmonary artery. It may be a residual of the original homograph that was in there that was left in place, and so that was stenotic at the pulmonary artery bifurcation. And so the next picture, then, we did this again with looking at the conduit here. And you can see the proximal conduit really looks pretty good. It's just the distal part. So we thought, well, we have the balloon right there where we would need to put a stent in that distal part of the conduit. And so then we did another another inflation and injection in the coronary. The next picture. Yeah, so now this is maybe a little bit more proximal, but still shows the right coronary arteries filling pretty well when we have the balloon more distally in the conduit. So we thought, with that picture, and the next one, yeah, even a little bit more distally, and we're even better satisfied there that the right coronary artery now is not being disturbed at all with that injection. So we're going to be out distally in the conduit, and so they thought, well, we should be able to put a stent out there right where that Atlas balloon is right now. And we measured that distance from the pulmonary artery bifurcation back to the proximal part of the conduit, and that measured about 35 millimeters. So we thought we should be able to put a stent in that position and effectively get rid of the distal stenosis and put a melody valve in that position. So what do people think about that?
Can you
We can see that
clarify
the
again,
artery
this atlas that you're using now is which diameter? 20, 22, or 24?
22.
22,
22.
okay.
Yeah.
Yes, we have a comment
And
from
with
our
that-
audience.
In the anteroposterior projection, there is quite a good amount of gap between the balloon to the right coronary artery orifice. So what is happening is each time the balloon is getting inflated, the right ventricle becomes suprasystemic. It squeezes all the myocardial capillaries that are coming out from the right coronary. You are filling the proximal right coronary, but you are not able to allow the blood to flow through and through. I think this is not a compression. It is just because of elevated right ventricular systolic pressure, markedly going suprasystemic, and it's not allowing the capillaries to fill.
Thank you, that's a good point.
Impossible to tell, but we were concerned. We didn't want to disturb the coronary if indeed it was being compressed by tissue outside of the conduit. So, but nonetheless, we feel that this position is quite reasonable for eliminating most of the obstruction. You see the RV pressure here in the hemodynamics now. It originally was systemic, and a little bit earlier it was actually 40. Now it's gone back up to 60, I think, because of the pulmonary regurgitation. But we think we went ahead then from this position and put a stent in the distal part of the conduit.
Jackie.
The next. Sure.
Just beautiful imaging. Do you have any concern about the distortion of the aorta itself? It does look at in the rotational, it does narrow significantly, but only in one view, and then wider in the other.
Yeah, I'm not sure. I don't think that it's the balloon that's distorting the aortic. It's a combination of the mechanical valve and the graft that's in the ascending aorta that causes that unusual indentation.
So in this setting, do you worry less because the patient has had Bentall procedure about pulmonary aortic erosion complication than a patient who had a native root with Ross and distortion?
Sure. I think that's a good point too, that we don't have quite that concern but it is an unusual orientation or relationship between the conduit and the aorta, that's for sure. But the next picture then shows, you see here with this injection that the outflow tract looks okay. We put a sheath up into the left pulmonary artery, and we placed here a 43 millimeter Andra stent on a 22 millimeter bib balloon. And the next one with some various inflations, we showed the position there. We're right at the distal anastomosis with the stent there, and maybe a little bit farther we were out. Next one. Yeah, so there we're happy with that position, being right at the distal part of the conduit. And then the next one, we should have one more picture here. And then we inflated the stent. Next one. And it stayed pretty much in that position. Nice inflation. Almost looks like it's about 22 by the balloon. I forgot how many atmospheres was that?
How many atmospheres?
Four atmospheres. 4 atmospheres. Okay. Okay. So then the next picture shows that the stent looks nicely positioned. And it has, I believe, covered part of the proximal valve anyway, so that the valve, I don't think, will be a problem if we put a melody valve in that, in the distal 2/3 of this stent. So
One more comment from our audience, please.
Yeah, I have just one comment about the 3D array, because generally this is no cardiac output injection into the aorta, so there is always some delay. It allows to fill the artery completely. So as a matter of fact, in terms of compression, it provides a very nice image on that. So this is, I think, the true condition. And I agree absolutely that maybe this was the problem with this peripheral part of the arteries and not the main trunk. So in such setting, when it's the case, maybe if, it could be done just in a normal way, and we could use a normal landing zone position. So what do you think about it?
I agree.
So, well, that's, I mean, I think right at this point, we think that the proximal conduit is not a significant area of the obstruction. We could remeasure those pressures, but I'm reluctant to put a stent in the more proximal part of this conduit.
I think your pre-cath CT showed quite nicely the right coronary to be remote. I would be interested in your predictions of this anatomy, Francesca. Is this one you virtually modeled?
That we what again?
They did not model it. But I agree that the impression of the reduced cardiac output, suprasystemic RV pressure may cause this appearance of right coronary compression, which then misleads us. And the proximal conduit's quite unusual appearing also. So I guess your pressure measurement will tell us about rehabbing that part.
Yeah, I mean, it would seem reasonable to stent that part as well at this point, and then go with the valve, rather than go with the valve now.
125.
Other thoughts from our audience? How many would stent the proximal conduit also at this point? Just a show of hands. How many would not stent the proximal conduit? How many have no opinion? Okay, we don't have many voters, but most would stent the proximal conduit from the small handful that rendered an opinion. But we'll let you proceed. Or perhaps you want to show us what else you did.
Mettimi una guida. Just putting again a multi-purpose to check the pressure again, and just to show you.
The pressure decreased. The pressure right ventricle decreased.
Gareth, please.
So sorry to interrupt, but if you look, maybe if you come even more caudal and look up into the stent, my impression is you've got some distortion of maybe the proximal end of the stent in that area of stenosis, which may, again, persuade you to add an additional stent to that complex. I just get the impression the Andrew stent's a bit distorted at its bottom end. I'm not sure what you think about that.
Yeah, can you give us a different angulation for the stent to show us its... Or have you been able to officially circularize this eccentrically compressed conduit?
I think it looks very good on the lateral and the free regurgitation back into the ventricle in that position. When you're looking at it on the AP, I think it is distorted. We'll see what the gradient is here.
Okay, flash.
So when you started your RV, systolic pressure was what?
Okay, stop.
Systemic. The same, and the arterial here is 126, and it's been systemic. So we have...
Okay, zero, please.
Actually,
Can you zero in?
We have RV and the pulmonary artery at the same time.
Yes. Of course. Come? The second we do zeroing again, please. Facciamolo zero, ragazzi. E tutte e tre le linee, anche la radiale, grazie. Okay. Just a second, we are zeroing again. Don't push. No. Lina? Lina, non toccare. Lina. Okay? So PA. The red one is PA, please. PA. The green one is the artery.
Okay.
And the yellow one, you see?
The right ventricle.
Right ventricle.
Okay. Gareth, what do you think now?
I have to say, even though it's not the "I told you so" thing. I mean, it's irrelevant to the gradient. I just wonder what people think about introducing a melody valve into such a distorted conduit, and I just wonder, from a flow dynamic point of view, even if there wasn't a big gradient, whether it might be better to rehabilitate the conduit further before relying on a melody valve to hold it open.
Yeah, the question about conduit rehabilitation and improving the hemodynamics as much prior to implant, and then potentially your landing zone for that melody to facilitate flow. What do you think about that concept?
That's,
The gradient is less. Okay?
Is I.
so that's the pressure in the proximal conduit.
We do not see your fluoro in turn. Oh, they're on the lateral, we see. So you do have a significant, you do have a multi-level gradient still.
So what
I
is
think
your
we have
suggestion?
shown the melody valve stent frame is not durable in this situation if it's not appropriately protected. Do you think you would have enough improvement in your hemodynamics if you just implanted melody distal within the existing one bare metal stent?
Yeah.
Yeah, I guess that's a question. So this gradient is about, still about 20 or so here, 22 for the, primarily in the proximal conduit.
The proximal.
I'm going to pick on our front row speakers. What would you do now, Martin or Jackie?
What do you think?
I think that
I think there is also some
We said we put a stent
reaction, muscular reaction. So what we do is an angio here with the peak, okay?
Jackie?
Yeah, I think that distortion in the stand and the way it looked angiographically looks pretty narrow proximally, and with the RV pressure being high, we would really push towards stenting more proximally with a strong stent.
Okay.
I fully agree with the previous speaker.
Okay, now we're seeing
Okay.
a few hints of systemic RV pressure.
Okay.
So I think most of us would vote for continued conduit rehabilitation. We have about 5 minutes before we go to Leuven for their case. Perhaps you would like to tell us your additional thoughts at this time.
I don't think, my personal impression is that the conduit is not creating a gradient. The distal part of the conduit is not stenotic. If you look at this angio in lateral, it looks like a muscular contraction, like a infundibular reaction, if you see. Because if you put my multi-purpose catheter, I check the pressure here, actually, the pressure is high, exactly, but not so high as the pigtail was showing us. What do you think?
I think you still have high pressure where your multipurpose is below that elliptical narrowing of the conduit, and your proximal stent is not circularized. So I guess I would go to my fellow panelists, but we're all kind of favoring another stent to rehabilitate this conduit.
Yeah.
So I think while you make a decision about that, we're going to go to Leuven for their case.
Nee. Iets terugtrekken. Iets terugtrekken.
Okay, I think we have transferred from Leuven to San Donato.
Yes.
We're back with you. Can you update us as to your case progress?
Yes, so we did another withdrawal, and it was obvious that the proximal conduit wasn't the problem, but it's the dynamic portion of the right ventricle just before the conduit. So we elected to compromise. We put in a melody valve in the more proximal part of the stent and inflated it there, and it looked very, very stable and in a good position. We have a picture that shows the melody valve and the...
Can you show next one?
So here's the melody valve, and we put it in that position right here. Next, the inner balloon inflated and seems in a reasonable position. The next injection is a full inflation of the melody valve in the more proximal part of the conduit.
Now it's okay.
And he was a little bit hypotensive here for a while, but eventually this all recovered. And we were satisfied with that position of the melody valve. The next picture shows the valve in, I believe, in a good position, and it's in the proximal part of the conduit. And then the next picture shows the two stents, and you can see they're quite circular. There's no evidence of any obstruction of the proximal part of this conduit. So we were happy that the melody valve was effectively eliminating any concern for proximal stenosis, although we didn't find any when we did a withdrawal.
So you have about 50% of the melody valve that is unprotected, correct?
Yes.
Yes, more or less.
Any comments from my panelists?
Yeah, I think
gradient?
I guess the result looks good. We'd be worried about the part of the valve being unprotected, and a simple thing to do is maybe put a 36 max LD on the outside of the melody and just put it in at the same time. That sort of, if you're worried about, putting another stent in and then having trouble getting the melody system in.
Right. So you can mount that on top of the melody and then inside the ensemble and deliver both at once.
Yeah.
Yes.
Yeah, it's a bit of a shortcut, maybe a bit lazy, but quite useful.
We talked about
Good hint.
that. Yes. It did. Yeah. So the RV pressure now is 60, half systemic. Do we have a pressure in the distal pulmonary artery? And we did an angiogram. This final angiogram here doesn't show the coronary really well, but it is filling. So the right coronary seems to be okay in this picture here. So this is the gradient here through this dynamic part of the right ventricle, about a 30 millimeter mercury gradient.
So where is your distal catheter is beyond the melody?
We have a catheter in the pulmonary artery distally, in the LPA. Okay?
We have a catheter out in the left pulmonary artery, and that pressure is, here, actually, it's better now. It's 42. Well, 34. Keeps changing. So 33 here in the left pulmonary artery and 58 in the ventricle. About a 30 millimeter mercury gradient.
Okay, and you said you had a final angiogram?
Yeah, we can do the final angiogram. Siamo pronti qua per fare. Secondo. Just test. Okay. Ready to go? Just move a little bit the table, please. Just like that. Okay. Ready to go? Inject.
And here, actually, you can see that in this upper part of the ventricle, where it is dynamic, the pressure is already less, so that the gradient across the conduit here is only about 11 millimeters of mercury. So I think that we're looking at a gradient of 11 through the conduit. Okay.
Very nice. Thank you. Any other questions from our audience? Okay, I thank you very much, and we are going to go to coffee break.